Great. Well, let's go ahead and get started. First of all, welcome everybody to the HeartFlow's Symposium. It's a great pleasure to host a wonderful faculty, and you'll see some really interesting and provocative new data which are coming out at this meeting. I'm not Jonathan Leipzig. Many of you may have seen he was on the schedule. I'm Campbell Rogers. I'm the Chief Medical Officer at HeartFlow. Jonathan wishes he could be here. He had somewhat of a family illness emergency and was not able to come to the meeting this year at the very last minute. So certainly many of us know him and care for him and are thinking of him and his family. And it's my privilege to do my best Jonathan Leipzig imitation. He's way better looking, way smarter. But I welcome all of you again on his behalf, and we send him our best wishes. So again, just a couple of quick introductory comments, and then we'll get started with our presentations. And I know the general sessions do start just around 8, so we promise you we will be done in time for people to get to those. The first couple of sort of framing points I would make are that in this, one looks around this meeting, sees the number of people looking back at the guidelines over the last couple of years. There has been an incredibly increasing interest and excitement and demand in the world of cardiac CT. The clinical value has been shown in multiple trials, including the PRECISE trial, which was presented last year and is expected to be published over the next couple of months. CT providers, many of you in this room are in that category, readers, providers, are being asked to do more and more and more with not necessarily commensurately more resources. And one of the things you'll see in the presentations today is really an attempt in gathering clinical data, hard clinical data, which speaks to ways to enable providers to provide CTA as a service to patients and other physicians in an ever more efficient and also ever more effective way. Gaining information from CT which has not previously been available, providing CT services more efficiently, et cetera. So that's, again, hopefully that will be a theme that you'll see as we go through these presentations. In terms of the faculty you see up here, I'm going to introduce all of them now, and then they'll give their presentations one by one, and then we'll have questions at the end as so far as time allows. Our first presenter will be Dr. Wesley O'Neill. Wes is the Director of Cardiac CT and Nuclear Cardiology at Cone Health, Heart and Vascular in North Carolina. So Wes, thank you so much for joining. The second speaker will be Professor Jagat Narula. Jagat is the Executive Vice President and Chief Academic Officer at University of Texas Health in Houston. Again, Jagat, with your incredibly busy schedule and life, we're so appreciative of your joining us this morning. And third is Sarah Rinehart. Sarah is the Director of Cardiac Imaging, the Director of the Cardiology Fellowship at Charleston Area Medical Center in West Virginia. Has been an incredible thought partner in the trials that you'll see, especially the one that she's presenting here at these meetings. And again, Sarah, thank you for your partnership in this journey. And without further ado, Dr. O'Neill would welcome your presentation.
So thanks, Campbell, and thanks to HeartFlow for giving me the opportunity to speak to you this morning. Let's see if I can figure this. May not be working. Yeah, I'll just use this. So I'm going to present to you this morning a study to measure the ability of AI CSQ to support the busy CCTA reader or smart CT. Disclosures are shown here. So just a bit of background, we all know that coronary CTA is now the first-line evaluation for patients with chest pain. There's a growing demand with coronary CTA, and it's going to continue to grow from projections. Coronary CTA can be quite time-consuming for readers, especially if you're in busy clinical practice. There are tools that are needed to enhance reader efficiency and accuracy. Visual assessment can also be challenging. I think we all know that. These are data from a Scott Hart sub-study, which really shows that variability in coronary CTA interpretation exists across even experienced readers. These are data from the core lab from Scott Hart, which, as you can imagine, there was pretty strong agreement for normal or minimally diseased studies, but very low agreement and even for moderate disease and moderate agreement for severe disease. So there exists a need to kind of enhance our reader variability or reduce this, which is what we see in clinical practice. So the SMART CT was designed to assess whether a commercially available AI-informed coronary stenosis quantification tool or roadmap can reduce coronary CTA interpretation times while maintaining reader accuracy and confidence. Also, the goal was to see if it would reduce inter-reader variability, which is known to occur in practice. So what is Roadmap, or this AI CSQ tool? This is a AI-based automated tool that's been clinically validated against quantitative coronary angiography. It's really been shown to have high diagnostic performance when compared to QCA, and these are some data that have been presented that really show the tool performs well with very high markers of diagnostic performance compared to QCA on a per vessel and a per patient level shown here. And just to summarize, you can see the AUC is fairly high for per vessel and per patient analyses. So the SMART CT study design, basically it was a trial designed by HeartFlow and conducted in the community. All patients had core lab analyzed quantitative coronary angiography data. Basically, the study design was to look at 60 cases without the AI CSQ analysis and 60 cases with it. Readers were blinded to the QCA results. CTAs were interpreted by both radiologists and cardiologists at 2 sites. This included 3 level 2 readers and 3 level 3 readers. To mirror clinical practice, coronary CTAs were read in batches of 10 cases per day, and this included a total of 12 batches or 120 studies. To mirror clinical practice as well, AI CSQ was also used, and local software was used for imaging post-processing as well as visualization and interpretation of the cases. The case order and use of the AI CSQ was determined by random assignment to ensure all 120 coronary CTAs were read both with and without AI CSQ by different readers. And this just shows you a diagram of what the study design actually looked like. The primary endpoint of the study was the average coronary CTA reading time with and without the roadmap analysis. Secondary endpoints included accuracy, reader confidence, and reproducibility. So this just shows you a figure of what the software looks like. All of the analyses show a spider view of the coronary trees. It only analyzes segments greater than 1.8 millimeters. It presents location and severity of disease. The location shown on the map there, highlighted by the minimal luminal area with an arrow. It also is color-coded, and also segment length of the lesion is shown here by the length of the capsule. It mirrors CAD-RADS2 reporting. Mild stenoses are represented in orange, moderate stenoses represented in red, and severe stenoses represented in purple. All of the data also shows centerline analyses or CPRs for all the coronary trees on subsequent pages of the analysis. So the primary endpoint of the SMART CT trial showed that when using this AI CSQ, readers were actually able to reduce their read time. On an overall basis for all readers, average read time for a coronary CTA with the tool was 6 minutes. It was nearly 8.1 minutes without the tool. This was a nearly 25% reduction in read time with the tool compared without. We also observed a similar reduction in time with reading between level 2 and level 3 readers with and without the tool. These data are shown here. Both were statistically significant, showing reductions in time regardless of training level. The data here shows the per patient diagnostic performance without the tool for stenoses greater than 50%. For level 2 versus level 3 readers. Again, this is without the tool. The data here show that the accuracy was greater among level 3 readers, which is not surprising, and this was statistically significant. The AUC was also higher for level 3 readers compared with level 2 readers on a per patient level. Again, this is without the tool. This is similar data showing the diagnostic performance on a per patient level with the tool. And this again is for stenoses greater than 50%, level 2 versus level 3 readers. And this clearly shows when the tool was used, level 2 readers read at a comparable level to level 3 readers on a per patient basis. All of the markers of diagnostic performance here were not statistically different. The data here shows per vessel diagnostic performance without the tool. Again, this is without the tool among level 2 versus level 3 readers for stenoses greater than 50%. And as you'd expect, this does show that level 3 readers outperformed level 2 readers, which is not surprising. Markers of sensitivity, accuracy, negative predictive value, and AUC were all higher for level 3 compared with level 2 readers without the tool. However, when the tool was used, again, this is per vessel, level 2 versus level 3 readers for stenoses greater than 50%. All markers of diagnostic accuracy were similar between level 2 and level 3 readers, showing a benefit of the tool to increase accuracy for level 2 readers on a per vessel level for stenoses greater than 50%. The kappa statistic for inter-reader agreement was also significantly higher for the AICSQ tool compared without. The data are shown here. Moderate agreement was shown at 0.48, and surprisingly, with the tool, the agreement was comparable to what was seen in the Scott-Hart sub-study, which shows that clinical practice can even mirror what's seen in a core lab. Without the tool, agreement was less favorable at 0.34. Reader confidence was also higher when compared on a 5-point Likert scale. When using the tool, there was a statistically significant difference in confidence compared with readers who used the tool versus without. So to summarize this study, the AICSQ tool that was analyzed in this study showed an overall reduction in coronary CTA interpretation time by up to 26%. Similar reductions in time were observed between level 2 and level 3 readers. The tool itself increased level 2 reader accuracy on a per patient and per vessel level for stenoses greater than 50%, showing its benefit that could be used in clinical practice in busy settings. The tool also reduced inter-reader variability, which is a nice feature, while boosting reader confidence. Overall, this tool really shows an aid to enhance our ability to interpret coronary CTA in busy clinical practice, as shown through this data. And I'd just like to give a brief background about our institution and our center and what we've seen over the past 5 years. We've seen tremendous growth in coronary CTA volume, especially FFRCT. Since we've kind of moved towards a CT first pathway, we've seen nearly a 7-fold increase in coronary CTA volume. This is also in line with recent guidelines. About 24 to 25% of our studies are sent for FFRCT. We've moved to a dedicated reader who reads nearly 15 to 20 per day, and that can really create problems for our institution, especially when you're busy and reading 15 to 20 studies a day. Overall, this has really shown a huge impact on our cath lab, which is not shown, but will be shown in the exhibit hall later. And then this shows the impact on our cath lab. Actually, we've seen a 25% increase in revascularization here at Cone Health. So how do we use it? We use it up front when the coronary CTA is ordered. All of our studies go for this analysis with this roadmap tool, and then the reader is able to effectively triage their read to determine where to focus their time. It also is a good way to remove your normals and mild disease so you can really focus on what you want to do with it. It also really enhances our ability to appropriately get FFRCTs ordered, and then this is just a general statement which mirrors guideline recommendations of the 40 to 90% stenoses. But it really has shown our institutions really have been able to effectively use the tool to increase our efficiency as well as increase other aspects, including improving the ability for level 2 readers to read more accurately. So I'd like to thank my co-authors for this work. And thank you for the opportunity to present this.
Thank you, Dr. O'Neill. Dr. Narula.
Thank you, Charlie. Thank you, Campbell. So I'm supposed to be talking about the REVEAL plaque study, which was recently completed and being presented immediately hereafter. But when I was discussing it with Campbell, Campbell wanted that I should give a bit of a background here as to why did we go for the REVEAL plaque study, and why exactly did we talk about the plaque characterization and then what would be the advantages of precision plaque quantification. So my disclosures, the REVEAL study was sponsored by HeartFlow, but I don't have a conflict of interest. I've attended one of their scientific advisory board meeting. I've had no honoraria in the last 1 year. And I do admit to a major conflict of interest here. I'm a die-hard fan and proponent of CT angiography imaging, specifically vulnerable plaque, which I was just talking to Tara a few minutes ago, and she says that you are not unique here. So, well, so we have often talked about this issue of whether we need to talk about anatomy, we need to talk about physiology or pathology. But we have always carried this dogma that 70% stenosis is the most important thing, and that should be the way to go after the revascularization. So why did it all start, and where did this start? So obviously, coronary artery disease is bad. Why is it bad? Because it leads to hard events. Now, we believe that there is progressive atheroma, and there is a significant, that leads to significant stenosis. It induces ischemia, and once there is an ischemia, there are events. And if that is the dogma that we are following, then obviously it's easy to manage that. You find coronary stenosis, since it causes ischemia. You find ischemia, since it causes events. Then you treat the stenosis because it will reduce ischemia, and then it is likely to improve the outcomes if we fix the stenosis and reduce the ischemia, and we hope that everything is okay. Where did this dogma come about? And it was based on all those mega surgical trials that we had seen in 1980s and early 1990s, where we found that the people who had 70% coronary artery occlusion, and when they were subjected to the coronary artery bypass surgery and compared to the optimal medical therapy of those times, late 70s, 80s, and 90s, and those people, they did much better with revascularization. As you can see here, the 5 years trial, it did very well, and then the extended trials also demonstrated that it was a sustaining outcome benefit with the coronary artery bypass surgery. It's not only that, the freedom from angina as well as the exercise tolerance, they all increased in the patients who had who were subjected to the revascularization arm. Now, where did this 70% come from? The 70% came from the positron emission tomography and some of the other coronary flow physiology in the canine experiments, where a single artery, the normal coronary arteries in dogs, where a single artery was blocked, and it was demonstrated that the coronary flow reserve started to dip after the 70% of occlusion. So we have continued that as a dogma to treat our patients. Now, these coronary lesions from those times, were those lesions similar to the lesions that we see today in absence of statins? So if you look at the papers from those times, specifically the pathology papers from Dr. Michael Davis's group, which comes from the UK, you would find that the coronary arteries, even if it was a stable coronary disease, and why do I call this as a stable disease? Because you've got a very significantly thick fibrous cap here, and when the fibrous cap is thick, the lesion is likely to be stable, even though there is a large necrotic core in this. Can this become unstable? Yes, but currently this is a stable lesion compared to those which are the high-risk lesions, which are full of necrotic cores, but they have got very thin inflamed fibrous caps, and at the thinnest site, at the time of hemodynamic perturbations, they give way, the plaque is ruptured, and then the thrombus is formed on top of them, resulting in acute coronary events. So, also, at that time, now that we did not have the statins, beta blockers were barely being given, aspirin was or was not being given, we did not have the angiotensin converting enzyme inhibitors or angiotensin receptor blockers or other drugs at that point in time. So the question was that would we need the trials again? And here was the most courageous attempt by Dr. Bowden and his colleagues when the Courage trial was presented. And this was a large number of subjects, a 5-year follow-up with the PCI plus the optimal medical therapy, which was the current medical therapy, compared to the optimal medical therapy alone. And as you would see that at the end of 5 years, there was no difference in the survival free of death or myocardial infarction, be it revascularization arm or be it the optimal medical therapy arm. However, even though there was a significant decrease in the number of PCIs after this study, there came the FAME family of trials where they looked at the fractional flow reserve and demonstrated that the presence of ischemia was necessary for the benefit from revascularization. And in the FAME2, when they compared those with abnormal fractional flow reserve, those subjects, when were randomized to optimal medical therapy or PCI plus optimal medical therapy, they demonstrated that those with the abnormal FFR did significantly well or better than those on optimal medical therapy alone. However, I would like to draw your attention to the y-axis here. You will look at the primary endpoint, which is the percent incidence of death, myocardial infarction, or the need for revascularization. And the study reached its endpoint within 7 months after the initiation, and the study was prematurely stopped. And it was suggested that the abnormal FFR may become our gold standard for revascularization. Now, how do you reconcile these two results, that of Courage versus the FAME? And here you can see that the results of FAME2 were essentially based on the revascularization. The myocardial infarction and death were no different in these subjects, except that the myocardial infarction was somewhat reaching towards the trends towards the benefit. But essentially, the results were completely driven by the need for revascularization in these cases. When Dr. Bowden wrote an editorial in New England Journal of Medicine on the FAME2 trial, he reanalyzed his Courage trial and demonstrated that the need for the revascularization was similarly much greater in the subjects on the optimal medical therapy arm, suggesting thereby that some of these subjects may require the revascularization, and it would be necessary that we identify these subjects ahead of time. But at that time, the ischemia trial was already on way, and we thought that that will settle the issues. But did that settle the issues at all? So in the similarly large number of subjects, 5-year follow-up, and you see that again, there is no difference in the optimal medical therapy versus the revascularization in this case. But when this published their subsequent paper in Circulation a year later that demonstrated that the likelihood of the spontaneous myocardial infarction was significantly reduced in the arm that was subjected to revascularization. So spontaneous myocardial infarction rate in the conservative arm was about 6%, while in the invasive arm it was about 3%. So the absolute risk reduction of 3%, relative risk reduction of more than 50%. So now what does this tell us? Does this tell us that ischemia showed us the failure of revascularization to reduce myocardial infarction, or was it the failure of ischemia testing to guide the revascularization? And I feel the latter. Now, the FAME2 trial demonstrated to us also that at the end of 5 years follow-up in this particular case, 50% of the people did equally well on optimal medical therapy as compared to those who were subjected to revascularization. So these 50% of people did not have MI, they did not die, they did not need the revascularization, and their relief from angina was also similar to what happened in the subjects with the PCI. So what exactly happened? Why is it that certain people respond to the medical therapy whilst others may not respond equally well? So there was yet another subsequent study of the FAME2, which was done by Dr. Habib Samedi from Emory. And these investigators, they looked at the coronary arteries, they created the three-dimensional structures and analyzed the shear stress and demonstrated that when the shear stress was high, at that point, the likelihood of an event was significantly greater as compared to the normal shear stress, and it did much better than the FFR itself, suggesting thereby that there is something more to it. And what is that? This is probably the composition of the plaque, which is different, which leads to the shear, wall shear at that particular lesion level that resulted in an event. So, if you look at the evolution of this, you will find that we initially believed that the 70% lesion, everybody should be revascularized. However, courage tells us that that may not be true. But then the FAME2 comes in and tells us that we can take away 33% of subjects and reduce the cohort to 66% who would require revascularization. But the FAME2 study, when you look at their wall shear stress, you will realize that 50% people, again, can be taken away who may not require the revascularization, suggesting thereby that it is not only anatomy, it is physiology plus pathology, which may contribute to the anatomical stenosis, which we need to identify. So, with the CT scans, we did see, when we published this back in 2007 with Sadako Motoyama from Japan, large number of subjects, 1,000 people, where we looked at the plaque characteristics, and we had identified two important plaque characteristics, and we called them as two-feature positive plaques, those with large necrotic cores, as you can see here, the low attenuation plaques, as well as the positive remodeling. And when these were present, in the next 2 years, the likelihood of an event was about 22.5% compared to those which did not have these two features or two-feature negative plaques, when the likelihood of an event in next 2 years was less than 0.5%, giving us a hazard ratio of 45:1. Greater the size of the low attenuation plaque, greater the positive remodeling, greater the area or volume of the low attenuation plaque, earlier and greater was the likelihood of an event in this particular case, and we thought that we have found an answer. However, when we look at the 10-year data, 3,000 subjects followed for 10 years, you would see that high-risk plaques do remain high-risk plaques, that is those which are two-feature positive plaques, but you will see that there is about, in 10 years, there is about 2.5% likelihood of having an event in the non-high-risk plaques also. But if we tease them further, we find those plaques, they eventually result in an event which show the plaque progression over the period of next 10 years. So those which had significantly high-risk plaques but did not show progression, they would not result in an event, but those with or without the high-risk plaque characteristics, but if they show the plaque progression, it will demonstrate a likelihood of an event, suggesting that plaque progression is probably the most important characteristic of a vulnerable plaque. Not only that, in our study with Dr. Bjarne Nogard, in the reanalysis of the NXT trial, and with Dr. Jonathan Leipzig, we also demonstrated that there were two features which identify the FFR abnormality. One is the QCA, and second is the low attenuation plaque volume, which actually satisfies the Glagau phenomenon in these cases. So, our study, which is coming out in this month of JACC Imaging, again with Motoyama's group in Japan, where we look at the FFR-CT, less than 0.8, more than 0.8, HRP or high-risk plaque positive and HRP negative, you'll see that those with less than 0.8 FFR, as well as high-risk plaque, they definitely do better with the revascularization, while the one with only, either of these features, there the optimal medical therapy and revascularization are similar, while in the case of the normal FFR and normal HRP, the revascularization does not help. So, if we conclude here, The eligibility for revascularization based on anatomic and physiologic significance of lesions has been debated and suggests possibility of a role played by the plaque composition. Low attenuation plaque and the positive remodeling best describe the plaque vulnerability on CT angiography. Novel methods have suggested the feasibility of detection of plaque inflammation by CTA also. FAME2 demonstrated that not all hemodynamically significant lesions require intervention, possibly true courage type patients. It is important to identify lesions that could be deferred. Prospective studies are needed to define the role of plaque pathology in management of chronic coronary syndromes, that is, to define the event-prone population of ischemia. And finally, our entire experience has been based on the subjective interpretation of CT angiography, and AI-supported automated strategies need to be developed for quantitative plaque assessment at both lesion and at vessel level. And it is with this idea that the REVEAL plaque, which is a prospective multi-center study to analyze plaque, was begun, which was conducted in 15 centers, 3 centers from Japan and 12 centers from United States, with the PIs being Dr. Thomas Stuckey, Dr. Gaku Nakazawa, and myself. And so we thank all these centers for record time enrollment for the REVEAL plaque subjects. And so this study was the artificial intelligence enabled quantitative coronary plaque analysis that should be able to provide a more rapid and reproducible quantification of atherosclerosis. A multi-center and multinational prospective and quantitative blinded CT angiography analysis was compared with invasive reference standard of the intravascular ultrasound. The 15 sites, as I said, were participated from US and Japan, with more than 250 subjects enrolled between October of 2021 to November of 2022. The patients with known coronary artery disease and CT angiography showing stenosis, at least in one major epicardial vessel, were enrolled, where the FFR was successfully processed and there was a clinically indicated invasive coronary angiogram, and intravascular ultrasound was planned within 45 days of CT angiography. The CTA and IVUS final volume comparisons were undertaken in blinded fashion. AI-based CCTA plaque volumes were generated from the software, which has recently been FDA approved, from HeartFlow. The independent IVUS core lab at CRF did the intravascular ultrasound analyses, and the cases, 237 cases, 432 lesions, and 254 IVUS pullbacks were analyzed. And as you can see, the correlations here, they are absolutely astonishing. As you would see that the REVEAL plaque actually shows that you have got the 45 degrees slopes here, essentially one-to-one relationship between the AI-assisted QCPA versus the intravascular ultrasound analyses for the total plaque volume, the calcified, this which was the primary endpoint, and the secondary endpoint of calcified plaque volume and non-calcified plaque volumes, and the per lesion and the IVUS pullback correlations are shown here, which are all in the vicinity of 0.9. And you will see the bland Altman analyses, which are extremely tight and very close to each other. When we look at the low attenuation plaque, again, the relationship was significant, although one-to-one comparison, as you may say, although for most of the cases quite close, there were some cases where the assessment by the intravascular ultrasound shows the significantly larger volume, but that was predominantly in the cases which had significant calcification. And as we know that intravascular ultrasound does have issues of assessment when there is significant calcium as well as the large necrotic cores. And so if you look at the cutoff points here for 2 millimeter, 4 millimeter, and 8 millimeter square of the plaque, you will see that the ROC curves demonstrate an excellent correlation between the two techniques here. So with the limitations aside, the REVEAL plaque concludes that the AI-QCPA demonstrates excellent accuracy and precision with current reference standard of intravascular ultrasound, verified lumen volume, plaque volume, and lesion morphology. AI-QCPA demonstrates the potential for AI to enhance patient care and management strategies for coronary disease. By providing accurate quantification and characterization of plaque from CCTA alone without the need for invasive procedures, AI-QCPA offers significant clinical potential by providing a deeper patient-specific understanding of disease burden. Thank you.
Thank you very much, Professor Narula. Thank you. Dr. Rinehart.
Thank you for the opportunity to speak today on the DECODE results, which actually look at how we changed medical therapy in coronary artery disease in patients evaluated with the plaque analysis that Dr. Narula just discussed, the accuracy results. So my disclosures were as follows. So what we know is heart disease is the #1 killer of men and women, and we used to have significant improvement in our mortality. But in 2010, you can actually see that we actually have a mortality which is on the rise again. We know that statin therapy has improved our therapy significantly, and the lower the LDL cholesterol, the lower the risk of cardiac events. We also know that with statins, there's a very predictable amount of LDL reduction depending on the dose of statin that we use. Throughout the last 10 to 15 years, there's also been significant evolution in our pharmaceutical industry with the amount and types of medications which can lower LDL effectively and can actually be used in combination therapy. But there's also been a significant shift in the guidelines within the US as well as the European societies, which have gone from goal-based strategies to dose-based strategies of statin therapies to a combination of these targets where we're actually looking at a 50% reduction as well as low LDL thresholds. But it's important to note that we're not doing a very good job. So the GOLD registry is actually looking at real-world implementation of what we're doing with our cholesterol therapy in patients with ASCVD. And despite 73% of the physicians believing that lowering the LDL cholesterol to less than 70 is the ideal goal, that belief does not translate to observed clinical care, because only 1/3 of those patients are actually achieving a target of less than 70, so 2/3 have a remaining residual risk. But it should be noted that in 2022, we've also shifted so that our very high-risk patients should achieve an LDL of less than 55, and we're not even close to that target. When we look at what's happening in Europe, we know that the 2016 guidelines, the very high-risk patient targeted a LDL of less than 70 or a 50% reduction. The Da Vinci trial looked at how they were implementing therapy, and again, 84% of their patients were treated with monotherapy with only 1% use of PCSK9 inhibitors, but only 55% of the patients were actually at goal. In the 2019 guidelines, there was titration of those recommendations where now they wanted more than a 50% reduction and an LDL of less than 55 in that very high-risk cohort. So if we look at the Da Vinci patients who were enrolled, only 33% of them would be a goal. The Santorini results actually looked at how they were doing after the 2019 implementation of the guidelines. And it is important to note we are using combination therapy more frequently, and if you use that combination therapy, you were more likely to get a goal. But yet 20% of the patients were not on any lipid-lowering therapy, and 20% of the total patients were actually achieving their target recommendation. So when we look at all of this data, it tells us our goals are not being sufficiently implemented. And factors which may be contributing to that include inadequate risk classification and underutilization of those combination therapies. Thus, there is a true need for technology and artificial intelligence, as well as information dissemination, in order to help physicians appropriately risk stratify patients and be more aggressive with their secondary prevention therapy. We know from the CAD-RADS scoring system for our coronary CT results that they actually implemented plaque grading into the reporting structure. But it is also important to note that they made recommendations for any excessive plaque burden of P3 or P4, as well as CAD-RADS 3 or higher, to have more aggressive risk factor modification and preventive therapy. The clinical landscape is completely evolving, and we now know that higher total plaque volume is associated with worse outcomes. However, the clinical utility of these quantitative plaque analysis tools to guide therapy decisions has yet to be shown. We also know that there is information about plaque that does not necessarily apply to just our current state, but also our future state of disease. And beyond the biomarkers and traditional risk factors, the plaque volumes are much more predictive of plaque progression over time. So our study objective was to look at the plaque analysis tool in addition to the coronary CT to see if it led to substantial change in our management plan to patients with varied levels of calcium. Our primary endpoint was to look at the reclassification rate based on the interpretation of the CT report alone compared to the CT report plus the HeartFlow plaque analysis tool. What you can see is we have 100 symptomatic patients who had diverse coronary artery calciums and CAD-RADS scoring, and we had 3 practicing CT reading cardiologists, and we each reviewed the case individually as well as collectively as a team. So we reviewed the demographics, the medical history, the laboratory values, as well as the clinical CT report. And then we individually and then as a group determined our management plan and medical therapy. When we looked at the plaque analysis tool, we took that into account and we saw if our medical therapy would change based on those results. So this is the Freeman paper where we looked at these different stages and we chose one stage of medical therapy. And if we decided to add a medication to that therapy, that was considered a titration or progression of our therapy. So what we can see here is our mean age of patients was 63 with 41% women, 77% were non-Hispanic. There is a broad spectrum of risk factors as well as anginal presentations. And we use the chi-square test for statistical analysis to assess the differences in the 2 rates. What we found was our management plan reclassification rate after our plaque analysis review was 66%. So 2/3 of our patients were reclassified based on the plaque analysis tool. And this was found to be more significant when the calcium scores were over 400, the CAD-RADS was 4, or the coronary stenosis was more than 50%, and the LDL was more than 70. The primary reclassification rate was to intensify preventive medical therapy. When we actually took a subset of those patients and reviewed the CT images, our reclassification rate was 50%, showing that review of the images actually changed our therapy up front, but we still reclassified when we looked at the plaque analysis tool. So if you look at our stage 0 therapy, that maintained. Our stage 2 therapy was our primary selection of the upfront management strategy to include aspirin and statin. 3% were de-intensified of medical therapy whenever we looked at the management tool. and then 35% were maintained at the same level. But as you can see, we had a large proportion of patients that we up-titrated medical therapy from stage 2 to stage 3, and then we intensified those stage 3 patients as well with review of the plaque analysis. So the limitations of this study is that more data needs to be obtained on the actual thresholds of certain quantified plaque metrics that increase risk for cardiac events. And we do need data on reclassification in the real world and how this reclassification strategy may actually improve achievement of the thresholds and goals of therapy, thereby reducing overall risk or downstream cardiac events. The best way to illustrate what we did is by using a case example. So if we have a case of a 66-year-old female presenting with chest pain, we actually saw that her ASCVD risk score was 7.1%. She was symptomatic, she needed ischemic evaluation, so a coronary CT was performed. But if you note, she's not on any aspirin or anti-anginal therapy or statin therapy. Her LDL is elevated as well as her triglycerides. When you look at the anatomic findings, she has very diffuse disease with multiple segments involved. There's proximal disease, high-risk plaque, and coronary stenosis, at least moderate, and some severe distal lesions. However, her physiologic findings only demonstrated an FFR significant and very distal stenosis. So we felt that that did not necessarily deem that intervention was required because the vessels were very small distal to those lesions, and she was not on anti-anginal therapy. However, insignificant physiologic findings on FFR do not necessarily indicate insignificant long-term risk. So if we look at her nomogram, she actually has advanced disease for her age. Her plaque volume was more than 75%. If you look at her plaque findings, her total plaque volume was 377, which is a stage 2 plaque burden, which we know is associated with higher risk of events. In addition to that, what we see is that her non-calcified plaque volume is 5 times larger than the calcified plaque volume, and she had 3.4% low attenuation plaque. So when we looked at our staging for medical therapy, she was actually in the moderate plaque burden strategy. You could potentially, without the quantified plaque information, choose stage 1, or if you were more aggressive, stage 2 treatment. Our team initially chose stage 2 therapy because we wanted an aspirin and high-intensity statin of Crestor 40 or Lipitor 80 because of the stenosis severity, proximal location, diffuse disease, and high-risk plaque. However, when we titrated our medical therapy with the use of the quantified plaque information because of her percentile, the stage 2 plaque burden, the burden of the non-calcified plaque, but also the fact that we know that even with a high-intensity statin, her LDL would still be above that 70 threshold. So we knew that she was going to need combination therapy after that review. So our conclusions is adding the artificial intelligence quantitative coronary plaque analysis to CTA alone leads to a change in clinical care in 2/3 of our patient population. So thank you for the entire team to participate in this study, as well as Sarah Mullen, Nicholas, and Whitney Huey. Thank you so much.
Thank you very much, Dr. Rinehart, and thanks to all of our speakers. I think we have time for a couple of questions. If people have questions and want to come to the microphone, and we will finish just probably in 5 minutes so people can get to the opening session in plenty of time. Sarah, let me start with a question for you. Thank you for the presentation. So you obviously are very active running a large community lipid clinic in a preventive mode. Where do you see the value of the plaque insights in a truly clinical, not research, but a clinical setting? How would you capture that for people who are practicing in that mode?
So I think every person that I see in my prevention clinic, I look at the CT images, whether it's of the abdomen and pelvis, coronary, chest, to get an idea of their plaque burden. I think with the advent of coronary CT being used for our anginal patients, and especially the anginal equivalents, it gives us a more appropriate idea of what our target should be. Are they in that high-risk category, or are they in that very high-risk category? So instead of, I think we can expedite our clinical care or lipidology at a more upfront stage. It actually tells me I may need to look for other biomarkers that are higher risk, such as Lp(a), hsCRP, or other risk factors. So again, if I see that plaque analysis tool and I see those high-risk plaque findings, I'm going to be searching, taking a second look or dive into where is that other patient's residual risk. So it's not just about getting to the LDL, it's looking at where is that risk beyond the LDL once I get to that goal. So I think it just gives you a more long-term strategy.
Thank you. And Professor Narula, for you, a sort of similar question. Obviously, you are in a very large integrated healthcare system. As you think about moving both your cardiology specialists and your primary care network in this direction, how do you think about that? What are the key steps if there are people in the audience who are in that, as part of that journey today?
As I said, that I'm a die-hard fan of CT angio, essentially. And so as Sarah just said, that it probably is now whether we are talking about the primary preventions, community clinics, or we are talking of the hospital settings with the complex disease and all. I think CT angiography has to attain its status of being the gatekeeper for anything and everything. As we are now gradually going, we started as the negative predictive value and we wanted just to exclude the coronary artery disease. Then we wanted to come into the moderate type of a disease, demonstrated the importance of it. And now we come to a stage where we are now going ahead and going to triage the patients, that these are the people who need to go for CABG, these are the people who need to go for PCI, and these are the ones which could be deferred to the medical therapy, as we just discussed when I was presenting the data. And as you would soon be seeing the fast track study also, again, supported by you, thanks to you. And that even the surgeons should be able to go ahead, and Dr. Patrick Sirois is here in the meeting, would be talking about this study, and that it is going to become possible that we may not even need the invasive coronary angiograms and the people will be operated upon after the CT angio. But the more important is going to be that we are able to accurately analyze, we are able to identify stenosis, we are able to identify the functional significance, and we are able to identify the pathological importance of these lesions so as to make the right kind of a decision. And the tools now are available to us. The automated analysis of AI QCPA, the FFR assessment and all, I think it has really opened up the opportunities for us. The onus is on us as the physicians to be able to avail of that opportunity.
Thank you very much. So we're going to close now. I would highlight, if people have questions on these studies, they are all being presented at this meeting in posters. The two plaque studies later today, this morning, and the Smart CT study is actually, I think, is tomorrow morning as a poster. So if people have specific questions, find the authors at those posters and dive deep. And again, thank you everyone for joining, and thanks again to our faculty for some wonderful presentations. Thank you.